Please welcome our panel of experts to the stage. Dr. Marta Wosińska, Senior Fellow at the Brookings Institution Center on Health Policy, Michael Kleinrock, Lead Research Director for the IQVIA Institute for Human Data Science, and Heather Zenk, President of the U.S. Supply Chain for Cencora. Full transparency here, they are a member organization of our sponsor, HDA. Welcome.
Thank you. Thank you all for joining us. Well, I want to start, Michael, with you. You heard the previous 2 or 3 conversations this morning, and you're a data guy. I was wondering if you, when you look at IQVIA's numbers on the shortage crisis, what do you find is behind the drug shortages that we've been experiencing, and does it comport with what the other panels say is responsible?
So I was a history major, so I hoard like bits of data going back a long way. We did a report back in 2012 on shortages. There were causes, there were outcomes. When we revisited this last year, we saw similar things, but what I see is shortages are being caused by market events. And primarily what this is we had a backlog of generic manufacturer applications to bring generics to the market. So we fixed it. So FDA approved a whole bunch more generics over a number of years. Normally it was 300 or 400 new generics approved each year. They doubled that for 7 or 8 years. If you're late to market in an old generic, what's the number one way to get market share? Take the price to the floor. So what we saw in these shortages, we saw an intersection of 2 or 3 key things, but one of them is a big dominant market share player in an otherwise commoditized market, and a poor business decision. Generally, being shut down from an inspection is a poor business decision. This is a for-profit industry manufacturing drugs. If you can't do it profitably, it's because you did something wrong. There's other industries like that. So that's really what's happened, is you get somebody into a dominant position and then they tripped. That's what's caused a lot of these sterile injectable shortages. That's what's leaving us exposed. We talk about shortages as if they're all the same, but they're very, very different. And there's a totally different story I would give about ADHD or about GLP-1s. There's a totally different story I'd give about those. There's also shortage needs defining. We talk about 300 plus shortages, but those include stockouts. Those include the supply being in the supply chain, but actually in the wrong spot. So what we found in our report is that most of the time when a shortage happens, there's more volume showing up in our data than there was before it was announced, not less. So, Americans, we think shortage means I can't get something, and that's true. You can't get it, but that doesn't mean someone else can't. That doesn't mean that it's not sitting somewhere else in the supply chain serving patients with shorter waiting lists at certain hospitals. I was on a panel earlier this year where they were discussing where these chemotherapy shortages were stopping procedures in cancer patients for small community clinics, but larger cancer centers were largely unaffected. So where the drugs go is also important. And so when we talk about opacity, we talk about complexity, multifactorial. I love all the words. This is what I'm a data guy, that's what we do. And yes, it's complicated.
Marta, I know that people watching this, patients, their families, they have been clamoring for Washington to do something. And I know that your organization has put together a framework to guide policymakers at the national level on where and how to intervene. So what do they need to do? And that's a big question.
Yeah, that's a big question. If I could back up and say that, you have heard that different shortages require different approaches. I categorize them into 2 major buckets. One is the existing persistent shortages, of which largely are generic sterile injectable drugs used in hospitals. That's really where we need to be focusing. 63%. 63%. This is what the Senate Finance Bill is doing. So when it comes to existing sort of the persistent shortages that we have been experiencing, the Senate Finance Bill is the very first real step and serious step in addressing those kinds of shortages. And then there are the potential shortages. There's a lot of concern around our exposure to China in supply chains. we have yet to have a shortage that was caused by export restrictions. It hasn't happened. It's possible. It hasn't happened. The discussion about APIs, that's a very rare occurrence that we would have a shortage because of API shortages, but it's a very possible one. So we have a pretty good sense of the scope of the problem and which drugs we should be thinking about when it comes to the ongoing shortages. And the Senate Finance Bill really nicely tries to move us in this direction and try to solve the problem, the root causes of the problem instead of the market dynamics. Where we need to prioritize and where we need more visibility and where we need more strategy is the potential shortages. Just think about how many drug products there are. There's probably, there's multiple thousands of drug products, each with a different supply chain, each with a number of steps throughout the supply chain. How do we think about, we need to think about prioritizing this. There's no way for us to onshore all of the facilities. This has been said already. And so then the question is, how do we prioritize? And so this is, for example, where I see the MAPS bill being helpful. We have previously published a framework for how to prioritize and with colleagues and how to think about this. And we propose sort of thinking about three elements. Criticality, so is it medically necessary? Reach, so how many patients does this affect? And then also vulnerability. The MAPS bill would help us assess potentially the exposure of where the drugs come from and sort of assess the vulnerability. And using this kind of a framework, we can then start thinking about where the government would need to invest. Again, economics is driving us outside of the United States. We would have to reverse the economics if we want to reverse these trends. We would need to basically create subsidies one way or the other for that. And so again, how much money are we willing to spend on this? So let's be smart, let's prioritize.
Heather, let's talk about distributors. Help us understand the role that distributors play in the supply chain and preventing shortages, in reacting to them, and how important is really coordination and collaboration throughout the supply chain?
So coordination and collaboration is really what the distributor community does every day. We take very seriously that we service, as we said, 1,400 to 1,500 manufacturers every day. We're receiving inventory inbound into our distribution locations and also coordinating with multiple sites of care. And when we say a site of care and a healthcare professional, which, full disclosure, pharmacists just paid off the student loans, so my mom's quite happy with me this week. But needless to say, we're talking about large academic health centers. We're talking about an independent pharmacy in a small town. I grew up in a small town in South Dakota, and I take very seriously that my family receives pharmaceuticals from a small, independent, local entity. And we see collaboration also as an access point. So our role is, how do I provide access for multiple sites of care, multiple sites of entities that are providing care in the community? And it could be complex care. It could be an anti-cholesterol medication that's an oral solid, all the way to a clinical chemotherapy agent in the local community. And so realistically, we are, I heard earlier today, we're one of the first calls, and we are. And we take very seriously that connection with our manufacturer partners to say, if they would come to us to say, hey, we're going to have a little bit of a bump in the road with the amount of inventory that we can put into the US market. It may not meet the needs of the demand of the certain sites. Can you help us? And I'll say a word, it sounds like a swear word and punishment, but we use something called fair share allocation. So we make available to multiple sites of care as much inventory as possible versus putting it into specific, maybe large density areas or large academic health centers or large entities. We really do try to look at, and every single day make inventory available so every site of care can care for the patients that they have. I'll say it's somewhat of the gift that is not always the best to receive because we don't please anyone.
Right.
No one is happy. In a town where a good collaborative event, I think, is nobody actually gets a victory, everybody gets a small win. That's usually what we're going for every single day. But it is very complex. We have a lot of different places in the market. And we really also take seriously as a supply chain, how much efficiency can we bring to this? So how do we balance access and efficiency and solutions in the marketplace to provide that local care? We take it very seriously.
Michael, planning ahead by having buffer inventories is something that we've talked about a lot. What have you found regarding the effectiveness of that strategy?
Well, I've heard a lot about buffer inventory strategies after shortages, but we had them all before the shortages affect these molecules. So everyone had a buffer. We plowed right through it and distributed it before the allocations came into effect. So I think a lot about checks and balances. If there are buffers at the manufacturer level, how they get to the distributor level and then how they get to the purchasers is really what this is about. One hopes that we have thoughtful and an appropriate interpretation of where those buffers should go everywhere. One of the challenges I think for distributors is if not all of them are perfectly aligned at that moment, then somebody's going on to allocation, somebody else isn't, and they're getting a sale when somebody is humanely getting some stock for their hospital. And it reminds me and it forces me to sort of reintroduce this topic, which is not every purchaser at the end, not every hospital, if we're talking about hospital injectables, not everyone has the same resources. And so as a result, the ones with more resources have the ability to have enough stock on hand, have enough resources to serve more patients. And a smaller community center can't get there, and they're often the ones who suffer the most.
Yeah, I wanted to link it to an earlier conversation and make a distinction between stockpiles and buffer inventories. Right. A stockpile is when you take the drug, put it into a warehouse, you lock it up, and if there is a trigger event, a public health emergency, or you unlock it and you distribute it. Right. What I think we are talking about, and what we think is a better strategy, is to have a buffer inventory where instead of holding a certain, if that a wholesaler, instead of holding 10 days on hand or 30 days on hand, they will hold a much higher level on hand, and it's first in, first out. So there's no product that expires and can move through. And if there is a shock, there's a way to sort of have, it's a buffer, right? There's an ability there's some inventory to work with. So I think
are there enough entities that have those buffers? And if not, how do you encourage it? Because it's costly.
That's right.
You're keeping more on hand than you need.
That's right. So this is again, if as the government is thinking about how to engage, we have previously through some of our work, we have proposed having the government subsidize buffer inventories, and there are actually bills in Congress that propose something, those kinds of ideas, is to have for certain types of drugs for wholesalers to actually carry a higher level of inventory on hand. CMS has similarly proposed for hospitals to carry a higher inventory on hand. I think a lot of people who are actually in the field, in the supply chain field, will tell you that it's a very inefficient way to have the end users have allocated inventory. It's a much better, much more efficient and much less costly strategies to actually hold it upstream, either with manufacturers or with wholesalers. But CMS, in a sense, has to work within its own system. They pay hospitals. And so, this was the only way for them to do it. So I think it's not the stockpile as a solution. We should be thinking about buffer inventories, and they should be held upstream.
Heather, do you agree with what Marta said?
I do, and I think one of the key things from being solution-minded in this space is the distributors of the wholesaling community in the middle. We could turn that inventory, because again, we tend to hear stockpile is, I somewhat joke, it's in a bunker in the middle of, maybe Nebraska, and when we need
can't stockpiles contribute to shortages, right?
They can potentially. And so I think that we're really looking at, from that buffer side, can we move the inventory so there's never any expiry date, so we don't also, again, we're all in an environmental mindset on top of that. It would be a much greener also way to have inventory move through the channel and balance that expiry date that's precious in the market also.
Let's talk about onshoring. Michael, how important a part of the solution is onshoring?
I think it's a distraction. The economics that have driven businesses to favor lower cost of production are still here. If we take the long history view from Hatch-Waxman back in 1984 to today, we all assume that we have 90% generics, that as soon as a drug goes off patent, it immediately becomes generic and we get to pay pennies on the dollar, and it's fantastic, and drugs are cheap, and you can get your cheap prescriptions at Walmart, and it's fabulous. no one's ever followed that out 3 or 4 years past the patent expiry. When you have a drug that's 10, 20 years generic and making nobody any money, which is what is causing these shortages. What we have to realize is that this is not an economic thing worked out at a single drug level for a manufacturer, for a distributor, for anybody. It's a portfolio, it's an inventory. Generic companies make money by feeding on slightly higher prices as the drug erodes in that 12-month window immediately after the patent expiry. After that, it's a diminishing return. Those diminishing returns don't fund reinvestment in manufacturing capacity. So if we don't have a continued flow of new genericizing medicines to keep the generic industry swimming, they won't be able to keep making all the other stuff. Same thing for everybody else. You're not going to invest in buffer stocks or anything else if it's a flat to declining market that is becoming less and less relevant as newer medicines come along. You know, a lot of our shortages are really old stuff. They're the last thing left for certain patients, but there's newer, better medicines for some things that patient's not either relevant for or not using, or there's another reason to choose. So and sometimes there aren't clinical substitutions. But when you think about this question of what do we do with onshoring or offshoring or where the manufacturing is happening, I echo some of the previous speakers. The shortages aren't happening because a factory in a specific location is bad at their job. We have Delaware factories, we have factories in the US that we have generic companies that have gone bankrupt. This is not, they're American companies, it's not there. A lot of these overseas companies have US subsidiaries that employ American people. Finished goods are often manufactured here even if the active ingredients are manufactured elsewhere. So those are also American jobs. So you're asking a question about something which is, I think, fairly political. It's outside my lane to a degree. But the real question is, why are the economics driving certain behaviors amongst the participants? Manufacturers, wholesalers, purchasers, and ultimately patients, because they're a part of this too.
Marta?
So, I mean, going back to the earlier question that you asked me, it's about potentially prioritizing. I will say I get very nervous that where we're going to land with Congress is raise your hand if you want to onshore, and then money will be thrown at it, and we'll pretend that we solved the problem, and we ended up wasting a lot of money. If we want to be, we need to be really strategic about how we think about it. There's been a lot of discussion about onshoring API into the US. Well, although the ingredients for API might still all come from China. So what problem did we solve? We need to be thinking about full supply chains. We need to be prioritizing the supply chains. I mean, it really requires a strategy. There's another piece. So, for example, Asper has funded during the pandemic a number of manufacturers, but also glove manufacturers and drug manufacturers. But it's one thing to build a facility. The economics is still there. How are they to survive? There's actually an excellent article that I recommend you read in the Pharmaceutical Manufacturer that talks about how, this is sort of the Kevin Costner movie, if we build it, they will come. Well, the problem is they're not coming. And so some of these manufacturers decided, who got funded by Asper, now don't have the orders. One manufacturer actually does have a contract with this to make drugs for the stockpile, but they also are looking to do contract manufacturing. Some other manufacturers are switching entirely into doing contract manufacturing because there's just no way for them to be sustained, to sustain themselves in the current environment and the current economics in the United States. So if we're thinking about supporting infrastructure in the US and onshoring, we better think about how those manufacturers are going to survive.
Heather, the congressman talked about incentives. Do we need to, you think, have incentives in the United States as China has, as India has, to encourage production here?
I think to help our manufacturers compete at a level playing field, yes. To the point that Marta has, we don't know how the economics around it or the community around it will have to respond. It isn't the silver bullet that solves all, but it at least gets them in the arena to be able to compete in a way that they can with other global entities. We are in a global supply chain. I mean, every single pharmacy in America, every single health system in America, every single oncology, anesthesiologist, et cetera, every single product on those shelves more than likely have some type of international touch to it. And that isn't something that healthcare professionals are really taught or learn about or think that they're supposed to worry about when they're going to medical school, pharmacy school, nursing school.
Sorry, I just wanted to add, as I'm sort of thinking about, there's been a lot of discussion about what the government could do in terms of coming up with new programs, new incentives. What we haven't talked about is thinking about what government policies exist right now that might be contributing to vulnerability of supply chains and potentially to discontinuation. So I wanted to sort of flag too. There was a little bit of the discussion about the DEA. You know, unlike GLP-1s, which are really, sort of ramping up production, that's right, the Ozempic, manufacturers have a great incentive to expand capacity. And so they're investing billions of dollars, and it's hard for them to ramp up fast enough. With ADHD drugs, those are not hard to make drugs. There's plenty of manufacturers that are willing to manufacture these drugs. The DEA is not allowing the quota to rise. The quota for ADHD drugs has been flat for the last, I think, 5 years. And
they're concerned about abuse.
They're concerned about abuse. And so this is an issue of actually a government policy standing in the way in resolving a shortage. Another example where there are sort of concerns is Medicaid inflation rebates. And the way they're structured, a manufacturer might actually not raise any prices, but they might end up paying a penalty. Also, it depends whether they came on the market before April of 2013 or later, because then they have a different benchmark for the inflation rebates. And what this means is that they have a different level of potential margin in the market. I've testified with Senate Finance that if they were to actually put forward their proposals, the idea is that you pay hospitals more for reliability, for buying from more reliable manufacturers, but then there needs to be pass-through to the manufacturers, right?
Yeah.
And ultimately, we're doing this so that the manufacturers have an incentive to invest. So there needs to be some pass-through. And Medicaid inflation rebates and 340B actually stand in the way, because here we're going to have the hospitals will get paid more, but then they have to pay it back through a 340B back to the hospital, right? So it just doesn't work. So there are other policies that really need to be addressed for us that are existing policies that we need to address. Yeah.
I want to bring Michael in because we're going to go to audience questions here in just a moment. But Michael, before we haven't touched on this, and I understand they do play a significant role. Group purchasing organizations, what are they and what role do they play in these shortages that we're experiencing?
Yeah. Well, so it's a good jump off from my past comments. If you think about the different institutions and purchasers in the system, they don't all have the same resources. And so your small little clinic in my little area in Maine doesn't have the resources of a large multi-state institution. So a group purchasing organization, GPO, essentially is an intermediary to negotiate on their behalf. Puts them in a pool with a bunch of other smaller institutions who can then come together, get a good price, and essentially they're your guy. So they're going around negotiating to get better prices for those groups who have less leverage.
So you're saying they're driving this race to the bottom in prices?
Well, yeah, and I mean I think there's it's important to understand that for hospital products, there are some medicines which are costly enough that they have their own specific price, and then they're reimbursed in one way. And there are others which we have a system of bundling and DRG codes, reimbursement basis, the code words, that drive more of the race to the bottom. But I want to link this more to the triple dipping that seems to go on, because you have your 340B. These are discounts for hospitals that do care for the indigent, low-cost care, children's hospitals, cancer centers. But they get to buy at the lowest price in the market. Then you get Medicaid prices, which are the lowest prices in the market. Then you get the inflation penalties in these things. And policies all come in because something happened. So there's not lack of reason.
There is a reason.
But you have all of those added on, and then we have GPOs who are also trying to drive the best price in the market. So we have multiple reasons why there's a race to the bottom, but you describe it as if the price goes down, but it's not always the price. It's the purchase price, and then there's a reimbursement price, and there's a spread, and there's different things going on, and
So
it's complicated, and I'm dancing now with my hands. It's a thing we do. So GPOs have a critical role, particularly for low leverage purchasers, low leverage care providers in the system. That's what they do for them, is they level the playing field for them. And so it's really important to understand where the playing field is unlevel as we examine this. And it's not just for manufacturers, it's also for providers.
Right, quickly, let's go to our audience question. Lisa?
We have one final audience question for the day from Nancy Headland from MedNavigate. What research might be ongoing to understand the impact of drug shortages on patients?
I mean, there are a number of studies, I would say not enough, looking at the impact that shortages have had on patients. It's going to vary by the drug, right? With some drugs, if you don't have it, you might die. With some other drugs, it will be just very frustrating. If you think about ADHD, there's, kids might have a hard time sitting in school and might not be learning. This is a very different thing than if you don't get your carboplatin and you die early. I think because it's really drug by drug and specific, it's hard to sort of do systematic studies. There are some really great examples. There was a really great study of a drug that's used with sepsis, and the researchers looked at what happened after there was a severe shortage and patients were switched to another drug, and they saw mortality rates significantly go up. There's an unpublished analysis by the FDA that took the number of deaths that resulted and did an estimate of this one shortage in terms of the costs that the government uses in terms of the value of life. And the cost for that one shortage turned out to be $13.7 billion. This is just one shortage. We could probably use more studies like that, just so that we can really appreciate the scope. And then if you think about, how much money should we be willing to spend, that $13.7 billion is a good number to remember.
Well, I'm glad that last question brought us back to the patients, because I think that's what this is all about. They are the ones, they and their families, who are suffering so much. I really want to thank you all, Heather, Michael, Marta, for joining us for this important discussion. Obviously, there are no quick, easy solutions, no silver bullets. It will be complex, but thank you for joining us. And just sit here as we wrap up. Joe?
Well, thank you all for attending today. I want to thank all of our wonderful speakers. I'd like to thank the Healthcare Distribution Alliance, and on behalf of the HDA and the Hill, I'd like to thank you all for coming, and the folks online. If you missed any part of this today, everything can be found at the Hill, at thehill.com. And the people in the audience, I welcome you to go next door and continue the discussion, and hopefully you'll join us all again soon. Thank you all very much.